morning, everyone. When Norley asked me to take over from this morning, I qualified as a physiotherapist in 2014, but I'm an early career researcher, regardless of what age I am. So obviously the research has aged me pretty well. When we were talking about the particular with regards to physical activity and exercise, I suppose thinking about what Prof. Kenny said earlier on is the why. So the main objectives that we're going to come through this morning is, I suppose as a physiotherapist, we're trying to always get people moving in some shape or form, okay? But as part of my treatment is education and advice. And if you could maybe take away something about the why this morning and maybe add it into what maybe some other topics that are coming through later on this morning as well. So I'm going to provide a high level overview, and I'll explain to you in a minute what I mean by high level, but also a high level summary of the evidence with regards to the interventions and the effects of exercise and physical activity. Hopefully set the scene first for some of the talks that are coming later on. And I thought I'd leave maybe more with some questions that hopefully where research is coming through over the next few years. So not to educate the educated, but because I'm providing a high level of summary here this morning, if you can remember back to your evidence-based practice pyramid, we're talking about the very high level, the meta-analysis, and then the systematic review. So if the meta-analysis aren't available, we go to systematic reviews aren't available, and so on and so on and so on. So with the meta-analysis, what they do is the researchers add all the randomized controlled trials together to pool the information to come up with one effect. And that's what I'm going to go through this morning for the different populations. And as I say, it's a high-level summary. Unfortunately, I don't have the time to go through an in-depth critique of the research, but generally they are based on aerobic interventions and mostly moderate intensity. So there's a bit of a theme going through to what Prof. Kennedy was referring to earlier on with activity. Interesting, exercise is medicine. The University of Limerick only last week have been chosen to set up in conjunction with the American College of Sports Medicine, the first exercise medicine centre in Ireland. I'm not involved with it, but from what I understand is that every other university in Ireland has a member on the board. So this exercise is medicine centre, brand, copyright if you want to talk about it, is going to be looking at the research over the next, hopefully 10, 20 years, but hopefully in specific populations, not just the sedentary or the active people and so on and so forth. So keep an eye on it over the next few years. As I say, it's just recently set up, and the American College of Sports Medicine have obviously put a lot of money into it. Bit of a history lesson. You didn't get a history this morning, but if you think back, unfortunately, if you back to your history level, back to junior cert and leaving cert, Hippocrates said, walking is man's best medicine. There's a reason why, and if you think back about Galen and following through to the 20th century, there's probably a bit of a difference between what Hippocrates and Galen were talking about, because they were more interested in focusing on health, no disease, the central role of the person. Whether, if we're honest, the way the medical professions sort of come through the 20th century is more to do with the sick care. Now, thankfully, that's changing, particularly with Healthy Ireland and so on. They're looking more at disease prevention and so on and so forth. And if you look at it recently in the past decade, the World Health Organization in 2020 and the Lancet publishing their seminal work on physical activity, there's obviously been a lot of progress, but there's been a lot of challenges as well. And if you look at the recommendations for the World Health Organization, the American College of Sports Medicine, and other different organizations, they talk about this 30 minutes, 5 times a week of moderate intensity, or the 75 minutes of vigorous intensity, plus the 2 days of strength training. So there's a reason why all this is sort of coming through, because I suppose thankfully a lot of the organizations are more or less singing from the same hymn sheet. So before we go on to maybe the rheumatology slant, thinking about the gerontological and the rheumatology together, there's a lot of meta-analysis have come through over the past few years, and Sherrington et al. Looking at the falls prevention, which again is part of our cohort, but it wasn't necessarily in the populations that we're looking at. Exercise as a single intervention can prevent falls in community dwelling older people. So they looked at 11 RCTs, pooled the information together, and they said that the effect it challenged the balance, and there was a higher dose of larger effects. Blood pressure, resistance training, which we know will come up later on, lowers systolic, diastolic, and mean arterial pressure. The magnitude of effect may be large in hypertensive males. That should be greater than 45 years. Depression, large cohorts of meta-analysis coming through over the past few years, including with those with a manic depressive disorder. Looking at my own PhD, we did a meta-analysis with meta-regression in people with rheumatoid arthritis, and we found significant to moderate, small to moderate reductions in depressions and anxiety symptoms in people with rheumatoid arthritis. 12 RCTs based on aerobic, and again using the physical activity guidelines of roughly about 2.5 hours per week. That's just impressive amount. Cognitive function is the same. Physical activity improved cognitive function in the over 50s, regardless of the status of the participants, and again in MS as well. Looking at it particularly for the rheumatoid arthritis and other arthritis populations, over the past 10-20 years, there's been a lot of more significant increase of in OA, RA, ankylosing spondylitis, and lupus, which we'll have a look at now in a minute. But again, if you can go back to thinking that the falls, the cognitive, the depression, the anxiety is obviously a very, very important part for our patients. So the first Cochrane review was done in 1998 by Els van den Ende, and they found out that dynamic exercise is safe for people with rheumatoid arthritis. It was updated in 2010, 8 trials, 575 participants. So again, just going back to the meta-analysis, we are looking at the RCTs, the powered information, pooling the information together to get one effect. Aerobic capacity, again, training combined with muscle strength training is recommended as routine practice with people with RA. Again, same recommendations of the ACSM, the WHO, Healthy Ireland, and so on. A very important paper last year with Metzius and Kittas was published, and they looked at the benefits of physical activity and exercise in people with rheumatoid arthritis. And they divided it into 3 different outcomes. There's the disease-related outcomes, the systemic, and financial costs, which is another story altogether. The disease were fatigue, inflammation, function, systemic cardiovascular risk, body composition, and the reduced hospitalization. There was no information with regards to sleep, so excuse the plug. My PhD was looking at the effects of exercise and sleep and mental health in people with rheumatoid arthritis. There was no systematic review. We conducted it. There was only one RCT that was available, and that was Dr. Laura Durkin, who's a rheumatologist here in Dublin. So the research is still very much in its infancy. Sleep, I could talk about till the cows come home, but again, I just want you to be aware that we did some cross-sectional studies, and we looked at subjective and objective physical activity guidelines, meeting the ACSM guidelines, and using SenseWare as the objective and subjective. Both came out that those who were more physically active slept longer, had better quality sleep, and lasted longer with regards to any inflammatory conditions with regards to their inflammatory biomarkers. So it's an area of research that is ripe for I suppose expansion. The Irish Research Council and the HRB thankfully are coming on board with regards to grants and scholarships and so on and so forth. But as you can see, sleep is totally different to fatigue, but sleep has always been sort of lumped together with fatigue. So in the next few years, hopefully there'll be a lot more information on sleep, which we can sort of get together with regards to a meta-analysis. So that's rheumatoid arthritis. The why, we can understand it because of the disease-related outcomes, the systemic outcomes, the financial costs. So moving on to osteoarthritis. Again, a couple of Cochrane reviews. Again, unfortunately, again, we can't go into the critique of them, but looking at them from a standalone point. Franson et al. In 2015 looked at land-based therapeutic exercise, and the best things that came out of it were reduced joint pain, physical function, and improved quality of life. Another Cochrane review in 2016 by Bartels looked at aquatic exercise for knee and hip or hip. And again, the same 3 things came up: the pain, the disability, or improved physical function and quality of life. So looking at the Franson one just a little bit more, and as an early career researcher, I still get the cold sweats when I look at a forest plot. So I do apologize for this, for a lot of information. But if you look at the left and the right, and down the very, very corner, you've got the favouring exercise and the favouring control. They had 3,500 participants, And if you look at the very, I suppose, the fourth one here, just coming up, the total 95% confidence interval, it was a 0.49. So it's a moderate size with regards to the benefit of exercise. 44 studies, so a very, very large group of RCTs that we're looking for. So that's the pain. What about physical function? Physical function had 22 studies. And again, if you look at the left to the right with regards to favouring exercise, there's more bands to the left than there are with the control. And if you look at the very, very last one, at 0.52 again, which is a medium size, looking at the using Crohn's effect size. Finally, quality of life, smaller increase, but again, still positive with regards to the favouring exercise. They have it changed for some reason with regards to the left and the right. So the why is anybody who has got osteoarthritis, whether it is land-based or aquatic exercise, the meta-analysis is showing us that there's improved joint, improved pain levels and so on. So the RA, the OA, looking at the ankylosing spondylitis, Cochrane a couple of years ago and crew looked at 8 studies with 331 participants. In this case, there was a lot of different exercises. There was the typical aerobic, there was the swimming, but also some resistance training, which again is obviously, as Prof. Kennedy was saying, anybody over the 40 age. Looking at the Bath AS disease activity index, you can see there's a statistically significant result in favour of exercise, and the same with the Bath functional index for people with ankylosing spondylitis. So looking at those a little bit closer, you can see out of the 7 studies, because Dermot had 2 parts to it, 6 out of the 7 show that the effective exercise improves the disability activity, and the same with the functional indexes as well. Looking at lupus, Dr. Tom Dwyer is a physiotherapist in 2017 and crew looked at it from 11 studies with 469 participants. Therapeutic exercise was safe. There was no adversely affect disease activity, but also more importantly, there was no change in the disease activity. There was improved fatigue. There was improved in the level of the reduced depression, and there was improved physical fitness as well. So I suppose there's a bit of a theme going through with regards to the inflammatory arthritis conditions with regards to RA, OA, AS, and now lupus. So again, looking at the forest plots, you can see with regards to there's a neutral part for the disease activity, but both fatigue and aerobic capacity were favouring exercise rather than the control. So we can see the why, but of course with our populations it's important to maybe understand, is it actually safe? Because it's pointless giving somebody and advising somebody just to do things for the sake of it. So a large systematic review and meta-analysis was done by Bess et al. In 2017. Now they looked at it from an inflammatory condition for all conditions, both RA, OA and AS. So from the ESR, there was moderate quality evidence for a small beneficial effect of exercise. No change in the CRP. Looking at the creatine phosphokinase, there was 2 RCTs that specifically looked at it. There was 22 studies in total for this the study, and I got the references at the very, very end if you want to do a little bit of bedtime reading afterwards. So again, there was significance for the phosphokinase and cytokines. If you look at the IL-6, as you obviously know, that IL-6 is both post and pro and anti-inflammatory. It's a good thing to have it actually increased after exercise. So looking at it from the radiographic joint point of view, moderate quality evidence for a small beneficial effect of exercises in the small joints, fingers and toes. Pain, small beneficial, but again, moderate quality evidence for the pain. Fatigue, moderate quality evidence for small beneficial. Stiffness, moderate again. Medium beneficial, but there was a low quality evidence for swollen and tender joints. Nothing in sleep, again, it's not there. It's still hopefully an area that hopefully in the next few years that there'll be a bit more information coming out with regards to the best that we can give people. So we know it's safe. We know the benefits. We know the why. But also looking at our population again with regards to the the type of areas that our patients might be involved in as well. Just thought it might be interesting that I just picked out a few more meta-analysis with regards to Nassi et al. In 2018. And systolic blood pressure. There was a lowering effect of exercise among hypertensive populations, similar to that of commonly used antihypertensive medications. And cancer-related fatigue, CRF, those exercise and psychological interventions by Mustian et al., they were effective for reducing CRF during and after treatment, and were significantly better than available pharmaceutical options as well. So we know the why. Again, high-level research, very much a summary, and very much aerobic, based on the WHO, American College of Sports Medicine guidelines. The theme is coming through. You might say, well, nothing has changed, but I suppose we have to start someplace, don't we? You know. So questions I suppose we need to ask ourselves: do the outcomes, or what other outcomes can we actually look at? And certainly the research with regards to exercise and mortality rates has I suppose the interest is increased, particularly though for sedentary people and those who are active. So for our populations with gerontology and rheumatic populations, there's still a lot of way to go. So just the question we just need to ask ourselves: does it have an impact on mortality rates? The theory is yes, but of course we need the research to back us up. The consort and the I don't know if you're aware, consort in 2010 guidelines and SPIRT guidelines in 2013, they were very specific with regards to the frequency, the intensity, time and type principle, the FIT principle, for when we put our exercise programs together for our patients and clients. So in other words, if I look at something, can I replicate it? And if I can't replicate it, why can't I replicate it? So certainly the journals and the quality journals, whenever we and this is what we found, whenever we've put a paper together, they really want us to follow, which is good, the guidelines, the consort and the SPIRT guidelines. But two things that are, I suppose, gaining in popularity and in importance based on those two guidelines, is the template for intervention, description, and replication, and the consensus on exercise reporting template. So they're items that you'd look at, that if we had an exercise program like walking, does it actually fit in, not just with the frequency, intensity, time and type principle, but also the 16 items of the CERT and the 13 items of the TIDIR. So there's a lot more going on with regards to replicating something. Question we need to ask is there enough evidence for the optimal dosage for exercise in various populations? And big thing is how to maximize participation. You know, thankfully we're all different, but human behavior and behavior change is a different thing altogether, isn't it? You know, and it's fine having the theory and the hypotheses of why we do something, and it's fine now hopefully that we have the why. I find as a physiotherapist, I'm talking to patients a lot more with regards to, why do you think you want to walk, or why do you think you want to put one foot in front of the other? And by gaining the trust of somebody, the idea obviously is that people will participate, behavior change will be changed. Is it reduced pain? Is it better sleep? We have to prove it, obviously. Is it better? Is less fatigue, depression, and so on and so forth. So the summary to take away from today, using the high level of evidence, there's an accumulation of high quality meta evidence that exercise is beneficial in rheumatic disease, in the RA, OA, lupus, AS, but also looking at the general meta-analysis from falls prevention, cognitive function, blood pressure, and so on. So it's fairly safe to say that it is the best drug. The question is, should the bar in deciding that be pushed higher? So I've got references on the other slides, and thank you very much for listening.